Good morning, everyone. This is Jen Sharon. We apologize for being late. We're having a little bit of a panic as I couldn't get signed on here, so apologize for making you all wait, but we have some great updates today. And we also have one of our BAM pilot sites here to talk about their success story to share their news. So I'm going to get right into it here. And remember, just post any questions that you have anytime during the presentation via the question tab, and we'll get to those at the end. And I'm going to turn it right over to Ryan.
Hey, good morning, everyone. Thanks for jumping on and hanging out while we got ourselves situated with the fun internet. But we're going to go over just some brief program updates for you all. And then like Jen said, we're going to talk a few things about some new things with teletracking and direct ordering that, Jen, your screen went away.
Yeah, sorry.
That's okay. With direct ordering and teletracking, which you probably or may have gotten some information on. And then Rebecca will join us and go over a couple of some of her experiences with the program. They've done a really nice job. And then Bill's going to jump on for some reimbursement reminders. So we can go forward, Jen. So as of 12/23, we've infused, well, you all have infused, I guess together collectively have infused over 160 patients, which is absolutely fantastic. And then about 67 patients, we've gotten reported clinical data. So thank you for those that are sending in that clinical data. And just out of those 67 patients, preliminary results, when we're looking at it, only 4 patients experienced a mild adverse event. And those mild adverse events were chills, fever, and headache. So again, with COVID, as we know, that could have just been a symptom. It could have been due to the drug. We don't know. But again, very well tolerated. 2 patients did expire post-infusion within the 7-day period. However, determined it was not due to Bamlanivimab. Both those patients were well into their late 80s and had multiple comorbidities along with of COVID. So again, really not due to the drug per se, but just due to disease and comorbidity. On the data collection tracking tool, there's going to be 2 new fields. One is if you are reporting clinical data, we somehow missed the date of Bamlanivimab infusion. And thank you to those that I've reached out to this week that have gone back and put those dates of infusion in for the patients that they have infused. That is extremely helpful as we're looking at the data. And then moving forward, for those that are reporting clinical data, we're going to include that. And then that'll be on the second tab where you put the facility information that you've infused and then that clinical information. The other field will be on the very front, the first tab of the data collection tool where you're putting in your specific pharmacy information. We are looking for the number of alternate requests and or no-goes, I guess you could say, that you receive. So for example, you get a request to infuse a patient at home, or you get a request to infuse a patient in a suite or in a physician's office or whatnot, and that's not able under the purview of our program. If you could, give us a generalized number, that'll be really helpful to give some of that feedback back to HHS as we work through the process. The other 2 requests that we're looking for are if anyone is willing to share their anaphylaxis or infusion reaction protocols with us. As we've been, I guess HHS has been acclimating some of the new administration to, as a result of the inauguration on Wednesday, they're doing some catch up and trying to re-educate or educate some folks that maybe aren't familiar with home infusion. And there have been some questions from other stakeholders in this whole process about, how do home infusion providers manage anaphylaxis and infusion reaction in the home? And so if anyone's willing to share their protocol, again, this would stay between just us and the folks at HHS, not anyone else. Please let me know, send that to me or reach out to myself, and then I can get those over to Connie, and Connie can work with HHS and those folks. I did want to call out next week, HHS is doing these Echo outpatient mini series on typically the mAbs and the vaccines. Next week, one of our members, Nancy Kramer with Optum, is actually going to be featured on this call to talk specifically about this topic, about how home infusion providers manage anaphylaxis and infusion reactions in the home setting. So the link is here. I would encourage all of you to join. Or if any of your facilities that you're working with still want to join, that's great. I think it'll be a very informative session. And then the last request is if anyone would like to participate and submit case studies on any of the patients that they've infused or their experiences, again, reach out to me. I've reached some folks I've had this conversation with, and thank you for those that have agreed. We are just looking for some case studies to compile that we can then have to present when needed. So Jen, we can move on to the next slide. So two other things that have come up and that HHS and our friends there have asked me to remind you is, over the last week, you may have gotten a couple of emails, one for teletracking and one for direct ordering from AmerisourceBergen. The teletracking is essentially the HHS reporting system for monoclonal antibodies, and that is what hospitals are doing at this point to report their infusions. So again, invitations were sent out to anyone that has received the product. HHS is encouraging people in our pilot to register for this. We're still going to continue at this time to report our data as we have been, where I will send out the data tracking form on Fridays. You will return it to me on Monday. By the end of the day, we're still going to continue in that process, but it has been recommended that all of our pilot participants do join and register for this. They don't have to do anything at this point, but to go ahead and register when you receive the teletracking invitation. If you didn't receive that invite, again, let me know, and I can get that invite sent over to you from the folks at HHS. The second is a direct ordering process through AmerisourceBergen for the monoclonal antibodies. Again, we're going to continue to order product as we have been through our pilot at this time, but it is encouraged that you would go ahead and set up that direct ordering process. Again, an email was sent out for that. If you didn't receive it, again, let me know. But in terms of ordering, if you would need product or you run out of product on hand and you need an expedited delivery, we can certainly do that with our contacts at HHS. So again, just let me know if you end up running out of product or need more product, and we can get it to you in a quicker fashion off of the normal cycle of how we order, which is we submit on Fridays and Saturdays over the weekend for the next week. So just if anyone has any questions about either of these, let me know, but we are encouraging folks to join. So the next, we'll have Rebecca go ahead and talk about her and her organization's experience. She's from Puder Infusion Therapy. She's their director of infusion, and they're located in Fort Collins, Colorado. So I'll go ahead and turn it over to Rebecca at this time, and she can just sort of share her experiences and what she's been doing with the program.
Thanks, Ryan. My name is Rebecca Dibicek, as he said, and I am the director of Puder Infusion. We have successfully administered 8 Bamlanivimab patients in our skilled nursing facilities. We are a unique infusion company. We do home infusion. We also have ambulatory infusion suites, and then we're owned by Columbine Health Systems, which has 5 skilled nursing facilities, 3 assisted living facilities, 4 independent living facilities, a physician group, a nurse practitioner group, a physical therapy group, a durable medical equipment company, a home care company. What else do we have? We really have everything post-acute to take care of a patient in our skilled nursing and then going home. So having us as a pharmacy and infusion provider has really allowed Columbine to be 5 stars in all of our facilities. I wouldn't say that the most of our business is in the skilled nursing facilities. More of our business now is in ambulatory infusion because we are that alternate site of care from the hospital. We've grown from 35 patients in ambulatory infusion to over 300 in the last 3 years, which is super exciting. This Bamlanivimab is super awesome to be able to provide something to combat this very strange and scary virus for our elderly population. I was very excited when NHIA had this pilot that we could do something instead of just sitting still. And I say that none of us are sitting still. This COVID thing has been nothing but unrelenting, confusing, PPE requirements, the changes in our clean room process, and then safeguarding not only our employees, but the patients that we care for. So having a tool to combat that virus was super awesome. In order for us to be successful with doing this in our skilled nursing facilities, I knew that we had to collaborate with that physician group for Columbine. I had to collaborate with the nurses, the director of nursing, and also the administrators from that group, from those facilities, to make sure that we had a good process of identification plus safety, and then making sure that we had good outcomes. So the computer system that the skilled nursing facilities use is called Matrix, and we all can get into Matrix and see Matrix. So that was kind of a no-brainer in order to create an order set that would be what's called a mail merge. And I don't know if people are familiar with Matrix, but that is what we ended up doing. And with that mail merge, it has on there the criteria for use, that we're communicating with the patient and Puder Infusion. So our nurses and our pharmacists are doing all the evaluation for this and then creating that mail merge in Matrix for that continuity of care. The physicians, the nurses, they're strapped taking care of those patients in the facilities with COVID positive patients, and they're not able to take admissions. They have less staff. So they've said, Pitt, you take over, you make sure that you're screening the patient, that they meet qualifications, and then get those orders to us, we'll sign them, and you come down and administer. It's worked out great. That mail merge is huge. With the mail merge, we're also doing an assessment in CPR Plus, which is our computer software. And that's what we're doing with the assessment, is making sure that we're meeting the NHIA pilot program criteria, and that we have a way to then track that 7 days later to do the assessment so that I can fill out that form to send to Ryan. And then we have a good reporting system. We've got documentation in our medical record, also in the patient medical record at the facility. And then the final step is making sure that we get all that information back to the facility so they can upload those documents into Matrix. So we get that to their medical records person, which includes the consent, and then that mail merge document that has been signed by the physician. Does anybody have any questions for me?
I don't see any questions coming through at this time, Rebecca, but we're going to keep you on because I know they're there. I think one question I have is how you're seeing the impact of vaccines in those skilled nursing facilities.
Okay, that's a great question. We actually have been able to inoculate all of our residents and staff with the first vaccination, and that's been touchy for us. If we would have been able to get the Bamlanivimab about 2 weeks earlier, we would have probably had 15 times the number of infusions we did. Time is not our friend. We have evaluated over 62 patients that were potential to receive this. Some of them were asymptomatic, some of them escalated pretty quickly with their disease, with the COVID, and required oxygen. Some of them were hospice and decided that they didn't want any interventions in their care. So out of those 62 patients that we evaluated, we only successfully have infused 8. With the vaccinations coming on board and the recommendation to wait 90 days, that's another reason why patients are deciding not to get this infusion. They'd rather get the vaccination than the monoclonal antibodies. So it's been strange. I really thought our uptake would be way more, but it is what it is.
That's interesting. We talked about that internally, where patients are opting because they have to wait for the second vaccine. So that might be something that we bring back to HHS, just to, if there's some sort of recommendation that they can give, because they have been talking about they should be treated with the MAB. That would be their recommendation at this point, and then wait for the vaccine, especially since they would be COVID positive and have that kind of built-in immunity. But yeah, we'll see what we can do to kind of get some more information on that, because we've heard that from other folks as well. All right, Rebecca, we're going to keep you on here as the questions come in, and I think we're going to move over to Bill now.
All right, thanks, Jen. The first few slides are a repeat of what I reviewed last week, but I thought it was important enough, at least from a resource, for you to have. The bottom of this slide has a link to NHIA's coding and billing reference for monoclonal antibodies. And the bullets here are based on some of the FAQs that we've received throughout rolling this process out. Next slide is a list of resources that are available. And that last resource is fairly new. I pointed this out last week, and the next two slides are a couple of the FAQs that I pulled from the updated CMS COVID FAQs. Next slide. We've received a number of questions regarding if a pharmacy can bill if they dispense the drug, but they're not actually infusing the drug. And CMS is very clear that the administration is to be billed by the entity that administers the product, and there is no separate payment for dispensing. So you could work through contractual, subcontractual relationships with whoever is administering, or you could subcontract and pay the entity that's administering the drug and submit the claim. Next slide. Some questions around SNFs. SNFs normally use consolidated billing, and outside entities aren't able to bill if they're in a Part A stay. CMS is very clear that this is an exception and allowable for COVID treatments. And the next slide is new information. It was a question that we asked CMS regarding place of service. And CMS got back to us stating that providers should use the actual place of service based on where the service was rendered or where the product was administered. So specifically SNF, long-term care, or nursing facility. The question has come about, and we've asked a follow-up question because we've heard back from one entity in the program that they got a denial for assisted living facility, place of service 13. So we followed up with CMS. They're looking into it. If you have any specific issues, please reach out to me. We've got contacts at CMS that we can work through, who would work with the individual MACs. In this case, it was California jurisdiction E, but there may be, different uptake and education required at the various MACs around the country. So if you have any specific questions or issues with denials, please let me know, and we'll assist where we can. And that was the last of my updates, Jim.
Great, thank you. All right, so the questions are coming in. First question, I think Ryan gonna be reiterating the protocol for if a patient can receive BAM once they've received the first dose of the vaccine and then tested positive afterward. Could you review that protocol?
Yeah, the current recommendations from CDC regarding that is if the patient does get the first dose of the vaccine and then would test positive and they're within the criteria of the EUA, the recommendation is to move forward with administration of the monoclonal antibody, in our case, the Bamlanivimab. Then it's a 90-day waiting period after the infusion of the Bamlanivimab. So it is fine if the patient has received, again, the first dose and then test positive and they still fall within that 10-day criteria of symptom onset and testing, obviously testing positive. that is okay. But again, you know, it does come down to the patient physician choice, because they would then have to wait that 90-day period after the infusion of Bamlanivimab. The second part of that question that was put in is, if the patient is in the hospital and tested positive for COVID, but now being discharged to the facility and will be within the 10-day symptom onset, can a patient receive Bamlanivimab therapy, or are they part of the exclusion criteria since they were in the hospital? That's an interesting question. If they were in the, I guess it would have to be, if you're looking at the criteria, if the patient was admitted to the hospital for COVID, they would be outside the EUA authorization. Now, let's say the patient was admitted for congestive heart failure and then was discharged to the facility, and then let's say tested positive once they returned to the facility, then that patient would qualify if they were within their 10-day symptom onset, for example. I know it's a little gray, but again, if the patient was admitted to the hospital for COVID, then they are outside and would be excluded from Bamlanivimab. I guess my hope and want would be that they would be treated possibly with remdesivir inpatient, because that's for inpatient use if they tested positive, or something along those lines. But I think if we have that situation, I will take that question back specifically. But at this point, again, if they were admitted for COVID at any point, my understanding and interpretation of the EUA would be that they would be excluded from the EUA.
Thanks,
and therefore
Ryan.
could not receive. Sorry. Yeah.
Yeah, that's great. Thanks, Ryan. Just want to remind people, if you have any questions, please put them in the question tab. We have only a couple left. This next question is, NHIA and HHS working with the states to increase awareness of the ability to provide BAM to patients in facilities? So I would say yes.
Yeah,
Ryan, you want to take that?
Yeah, I can take that one too, and then I know Connie's on if she wants to jump into, because we're doing some multiple things really. One interesting situation that came up with a provider this week was they heard of the pilot, weren't really sure, located in the state of Louisiana. They had a request, and so they called the state, and the state referred them back to our program. So that's a positive. So the states are aware of the pilot program. HHS is providing our provider list to them, and so that's a positive. Secondly, in terms of the facilities specifically, we actually have a second follow-up call with the American Healthcare Association today, which is sort of the association similar to how we oversee home infusion providers. They work with assisted livings and nursing homes across the country. And we're having a second follow-up call with them today to continue to have the conversation about the program and working with facilities and making them aware of our program, and how we can collaborate with them more to get the information out to those patients or those facilities that would have patients and that could utilize all of you who are enrolled to help administer BAM in those locations. So yes, we're actively working on that, and I know Connie's on. I don't know if there's anything else you wanted to add to that, Connie, and what you may be working on with Dr. Wong and team.
Can you just repeat the original question?
Yeah.
So, I'm sorry, I'm actually emailing back and forth with Dr. Wong right now.
What is NHIA and HHS doing to increase awareness of the program with the state?
With the states?
Yeah.
You know, we have really let HHS take the lead on communicating with the states about the program. And I know that they're sharing our website and the SPEED website with the states, and they also have a call with state health departments. So the information's getting out there. I think the challenge with the states is that they're still very focused on vaccines and just don't have a lot of bandwidth. What I'm actually working to do is try to help HHS understand where we're running into roadblocks with access. And partly, you know, that being a reimbursement problem and needing to increase the rate if they really want these drugs to be available to patients at home. You know, the rate is the primary barrier. And then secondly, you know, there's some process issues that have to be worked out. I think we've sort of overcome the access issues through this project, and then, you know, with the direct ordering, which I think would actually expand potentially. But there's also some, you know, education that has to be provided to physicians. And I know Ryan's going to mention some of the newer studies that are coming out that I think will help with that physician buy-in. But, you know, my message to HHS is your main barrier right now to promoting this product is the way you're using a one-size-fits-all reimbursement model that doesn't acknowledge professional services from pharmacists and all the work that we're doing to make it possible to get the nurse to the home.
Thanks, Connie. I think the other thing that NHIA is doing, we've worked specifically with our FIAC members, McKesson, as well as MHA, to put together resources so that they can share these programs with their long-term care facilities that they work with. So some of our larger companies, certainly, especially on the FIAC, that do provide services to those, they are partnering with NHIA to get that information out as well, and that's been extremely successful. And I would just like to thank McKesson and MHA for their work on this pilot and helping us get the word out. I have a couple more questions here. This one's going to go to Rebecca. When you were talking about providing the infusions in the nursing homes, are these occurring in the true skilled nursing beds, or are they more in your assisted living and independent living?
So they're actually in the patient room on the COVID unit. We want to make sure that those patients are not having to move or anything like that. So yeah, we go directly into the room and infuse that patient right there.
Great, thank you.
Yep.
And Jen, can I piggyback off that just really quick? And so just in general, for the 160 plus infusions that we have performed, we've been tracking obviously that facility information. And just to give you sort of high level, it's about 42% assisted living, and the remainder being in skilled nursing beds, so, or facilities. So it's roughly a 60-40 split that way. But out of the patients that all of us in this program have administered, it's about that 60-40 split.
Great, thank you. And there was a question, I think answered well by Connie, about whether we've been working with HHS to open up this BAM pilot specifically for home infusing use. And as we talked about and advocated for since the beginning here, is a better rate in order to make that actually feasible for home infusion providers. I guess the other quick question is, it's, it may be more of a statement that we'll, I think, agree on. It seems like each state has its own workaround. I would say for everything, that is probably the biggest challenge to manage the program, or anything outside the program, is every state is very different in how they're using BAM, how they're getting BAM to other sites, where it's being infused. And I think that's one of the reasons why when we talk to HHS about our providers need another avenue, should they get a referral outside the BAM project, that is going directly to HHS, since they have a much better understanding of what each state is doing. But I think the NHIA team would agree that it is frustrating, and it seems like it's very similar to the vaccines, that every state is kind of doing things a little bit different. That was our last question for today. Ryan?
Yeah, hopefully everyone can hear me. I just was going to add to recently this week, and Connie sort of mentioned it in her when she was answering her question, and I will provide a lot of this information for you. We'll get it posted on the website. There's been some studies specifically related to the successful treatment of COVID and SARS in the nursing home staff and residents, based on some studies that are being done. There was roughly about 1,000 residents and staff at nursing homes and other locations that were involved in this study. It was conducted through a partnership with NIH. But it was very interesting that, 80% reduced infections. And so in terms of the severity and things like that and symptomatic progression. So I will get that out to everyone and get it posted on our website. Those are coming out just yesterday and really the day before. So there's a lot of good good publicity. This is something that you could use when you're having conversations with facilities that maybe are a little bit, maybe leery or don't understand it all, to reference and have that discussion with them. So we'll get that information out to you, but it's really promising. And I think too is we're seeing good based on the information we're collecting in our pilot. We're, like I mentioned before, we're seeing very successful infusions, minimal side effects, and some good work happening and really good for the patient. So I'll get that out to you when I send out the data collection tool, and we'll get them references posted onto our website for the BAM pilot for you all to take a look at. But yeah, it's good stuff.
Great.
So.
All right, well, a big thank you to all of our BAM pilot participants. We appreciate all the good work you're doing, and we know it's not easy. And then a thank you to Rebecca for sharing her story with us. I would also encourage you, if you have a great case study that you have been able to successfully infuse, or would like to share the success of your organization, please reach out to Ryan and I. We love to have our BAM pilot participants share how they're making this successful within their organization. So please reach out to us, and we're happy to accommodate. So again, thank you, and I hope you all have a great day.